Hi, I am Dr. Abid Hatim, orthopedic surgeon at the University Hospital of Fez in Morocco. I am very honored to participate with this presentation, which deals with an important subject, namely the management of the hemodynamically unstable pelvic fracture patients by external fixation in emergency without angiography services available. By way of introduction, we can say that pelvic fractures account for 4 to 5% of all fracturated patients. In this context, unstable pelvic ring disruptions result from high-energy trauma. The most common mechanisms of pelvic fractures are motor vehicle accidents in 57%, pedestrians hit by motor vehicles in 18%, motorcycle accidents in 9%, falls in 9%, and crash injuries in 4% of the cases. In this lesion, the mortality rate ranged from 5 to 42%, and often it is due to massive hemorrhagic shock. Hemorrhage is the major contribution to mortality in 42% of pelvic trauma patients. Of this, 62% is due to pelvic hemorrhage and 38% is due to associated intrathoracic and intra-abdominal hemorrhage sources. No hemorrhage causes of mortality from associated injuries are related to head injury in 32%, followed by sepsis leading to multi-organ failure in 14% and cardiorespiratory failure in 8% of the cases. In this context, the immediate goals of treatment of the hemodynamically unstable patient with a pelvic fracture include advanced trauma life support and temporary stabilization of the pelvic ring. For saving life-threatening injuries must be identified and treated specifically in order of priority. For controlling hemorrhage from pelvic fracture faced with the availability of arteriography 24 hours a day, 7 days a week, external fixation which acts by tamponade effects can be required. Historically, the concept of fracture stabilization for hemostasis dates back about 5,000 years to the ancient Egyptians who splinted fractures with wooden sticks and roller bandages. The oldest documented surgical text in history is represented by the Edwin Smith papyrus, which dates back around 3000 BC. The modern history of pelvic fracture management has gone through three major periods. First, the Malgin era at the 19th century, led by Joseph Malgin, a French surgeon, and which was characterized in the absence of radiographic imaging by accurate closed reduction maneuver followed by bed traction in a pelvic sling for several weeks. Secondly, the Holdworth era at the first half of the 20th century, in correspondence to Sir Frank Wild Holdworth, an English orthopedic surgeon, during which the introduction of X-ray technology improved the diagnostic and the classification of these injuries and allowed the monitoring of the healing process. From a therapeutic point of view, the conservative attitude towards pelvic fractures was still in order. Pelvic sling with skeletal traction was refined. Then the third period, which started from the second half of the 20th century, conducted by Sutherland, Pennell, Young, Burgess, and Tyle, who contributed by their classification and the introduction of the concept of fracture stability to the development of therapeutic protocols and acute management of patients with pelvic ring disruptions. Worldwide, and with the growing number of high-speed vehicle accidents, car accidents are one of the world's leading causes of death, estimated over 1 million lives each year. On a national level, our statistics follow this global evolution with a constant increase of the number of vehicle accidents as shown by these graphs. In our context, we deplore an average of 3,500 deaths per year. The role of the orthopedic surgeon in the acute management and resuscitation of patients with pelvic ring disruption continues to grow, particularly with the availability of angiography services 24 hours a day as in our context. Through this work, we try to assess the role of external fixation as a resuscitative measure in the management of hemodynamically pelvic fractures patients without angiography service available, with a view to assist clinicians in providing a more selective evidence-based approach to the management of hemodynamically unstable pelvic fracture patients. For this, we have conducted a retrospective study spread over 5 years between 2017 and 2021, including 15 patients with unstable pelvic fractures who were treated at our department. Almost all injuries were caused by high-energy impact forces. All patients had multiple injuries such as lower and upper limb fractures, bladder, perineal, spleen, and sciatic nerve injuries. In the emergency room, we make an accurate clinical evaluation as part of primary survey, which consists in establishing and preserving breathing and ventilation, blood circulation, and brain perfusion. When the primary survey is completed and the vital signs are normalizing, the secondary survey can begin. It consists in orthopedic assessment, which surgeon pelvic deformity, limb length, discrepancy, or malrotation. At the clinical evaluation was always associated radiological assessment. Particularly, our pelvic trauma protocols includes X-ray of the pelvis and anteroposterior projection and the multi-slice CT scan with contrast imaging of the vessel. Unstable pelvic fractures were immediately stabilized by external fixation in 8 patients. Then, tertiary survey can start based on a careful and complete examination in order to recognize missed injuries and related problems reported in more than 10% of the cases. Concerning the technique of external fixation, we adopt the conventional method. Under anesthesia, the patient is placed in supine position. The anterior superior iliac spines, the inner and outer tables of iliac crest were identified by palpation. With use of hand drill, we insert 2 threaded pins directed inframedially under aseptic percussion just 1 cm above the anterior superior iliac spines with 40 of tilt from the vertical plane, with a space of about 2 cm between each pin. Pins are bridged by a straight rod, and the same procedure is repeated on the other side of the pelvis. Traction is given to correct the migration, and compression is applied to reduce the diastasis. In the following days after trauma, when the patient's condition is stable, the external fixator is checked, and if it is necessary, it is completed by positioning more pins. The study has patients of different age groups. 60% of cases were between 20 and 40 years old. 70% of patients had presented within 2 hours of injury. The fractures were classified according to tile classification, in which type B with 13 patients was the commonest, and type C was found in 2 patients. 6 patients had associated injuries, 5 patients sustaining other fractures, 5 patients had liver laceration, 1 patient had rupture of the right patellar tendon, and 1 patient sustained ureteral injury. Our patients were divided into 2 groups. A first, composed of 8 patients benefiting from external fixation immediately, with the survival of 6 patients, realizing a survival rate of 75%, and the second group consisting of 7 patients in whom an emergency laparotomy was performed in 4 cases for vessel lesions without external fixation of the pelvic fracture. In this group, 5 patients died, realizing a survival rate about 30%. Statistical analysis of this data based on Mann-Whitney U test and chi-square test with Yates correction enabled us to conclude that there is a significant difference concerning the saving effect of immediately external fixation in the case of an unstable patient with a pelvic fracture. In the literature, the majority of authors agree that in the case of hemodynamically unstable pelvic fracture patients, pelvic arteries and veins constitute the major bleeding sources. In this context, reported bleeding sites, sources of instability, are in 57% of the cases posterior, generated at this level by the superior gluteal artery, the lateral sacral artery, the iliolumbar artery, and the inferior gluteal artery. Anterior origin is incriminated in 43% of the cases generated at this level, particularly by the internal pudendal and the obturator arteries in 45% of the cases. The review of the literature shows that the 2 pelvic fracture classification systems most frequently used are the Young-Burgess system, which is based on the direction of injuring force, and the tile classification system, which is based on rotational and vertical stability of the pelvis. A significant correlation was reported between higher blood product requirements and the more severe type of pelvic fracture. In fact, the fracture causing major ligament disruptions increase probability of pelvic arterial bleeding. In the literature, the majority of authors agree that the management of hemodynamically unstable pelvic fracture patients requires a multidisciplinary approach involving various specialists. The authors agree on the priority to restore and maintain the vital functions, then executing the first-level checks. However, there is no consensus concerning the necessity of urgent and immediate pelvic fracture stabilization. In this regard, there are many authors who highlight the main role of pelvic stabilization in emergency to control the bleeding by reducing pelvis volume and the motility factor that promoting the blood clotting. For this, external fixation, which is a quick and easy procedure for pelvic fractures stabilization for experienced surgeons, represents the gold standard approach. In the presence of lesions of the abdominal organs or main vessel, it is absolutely necessary to do the pelvic stabilization before or during the laparotomy. The best results of pelvic stabilization obtained with external fixation are achieved in rotationally unstable pelvic fractures with a rate of 64 to 83% of cases. If vertical instability is also present, such as in vertical shear type injury, stabilization can be achieved in only 27% of cases, and additional skeletal traction is needed. In a prospective comparison with randomization of 112 patients with unstable pelvic fractures conducted by Waikakul, blood transfusion, postoperative pain, and skeletal deformity were less in patients with early external fixation. In a cadaveric biomechanical study conducted by Varas, in which three methods of internal fixation and external fixation were analyzed and compared, the authors observed that external fixation proved the most practical method in the resuscitation situation. In addition, external fixation to treat unstable pelvic ring fractures seems to be associated with a significantly lower risk of death, especially in patients with head injuries or associated fractures, as reported in these articles, including 1,163 patients for Omori series and 605 pelvic fracture patients in the Reimers series. In conclusion, the external fixation constitutes in our context a real life-saving method in hemodynamically unstable pelvic fracture patients. It is a little invasive procedure, fast-running in skilled hands, that allows a good mechanical stability and leaves the possibility of revising the abdominal cavity if it is necessary. Therefore, we will continue to adopt external fixation with great conviction for the management of unstable pelvic fracture patients. This concludes this presentation. Thank you for your attention.